cutis cilia in this case gets left behind, it can lead to subsequent interference with the femtosecond energy delivery. This leads to uncut areas which can lead to subsequent dissection difficulties. So as you can see, the dissection at the area of the uncut area is a little harder to do. Suction loss can occur because of sudden eye movements or the head movement. Following completion of the posterior lenticule cut, the opaque bubble layer obscures the visibility of the fixation light. So now, in order to prevent suction loss, the patient should be counseled that the green blinking light will disappear at this step, and the patient should be asked not to look for it. If the suction loss occurs when more than 10% of the posterior lenticule cut has been completed, the case has to be converted into a flap procedure. At all the other stages of suction loss, the procedure can be repeated with certain changes in the parameter. This is a video which shows a suction loss due to sudden eye movement. However, since more than 10% of the posterior cut was completed, the patient is redocked in the same sitting and it is converted into a femtosecond flap. In this particular case, the posterior pass has been completed successfully. However, the suction loss is occurring at the stage of the anterior cut. So the patient is redocked. Here, an ideal centration is of paramount importance. The centration following the docking is confirmed with the inbuilt infrared illumination. The treatment now starts from the stage of the cap cut, and the remaining procedure is carried out in the routine manner. During attempted lenticule delineation, an incorrect tissue plane identification can result in the primary separation of the posterior lenticule surface, which results in the adherence of the lenticule to the overlying stromal cap. So this video shows a difficulty in the subsequent dissection because the posterior lenticule, the posterior surface has been dissected first. The challenge now is to achieve an anterior dissection. So this can be done either with a sharp-tipped instrument or with forceps, as it's been done in this case. Once a small area of separation has been achieved, the remaining lenticule can easily be separated from the surrounding tissue. In certain situations, the extraction of the lenticule may be piecemeal because of fragmentation. So in order to avoid this, one should ideally make sure that the lenticule is separated completely from the surrounding tissue before an attempted removal. Moreover, following the extraction, the lenticule can be spread out over the corneal surface to ascertain the complete removal. In certain occasions, when there is a more difficult removal, there can be a side cut extension. This is a very common but a minor complication and does not affect the final visual outcome. One of the major shortcomings of the SMILE procedure initially was the inability to retreat a regression or an undercorrection. However, with the introduction of the circle software, the cap can now be converted to a flap. So this video demonstrates a circle scan in which the femtosecond pass begins with a junction cut. It starts now. It starts from the edge of the initial cap, and a subsequent energy is delivered peripherally, which converts it into a flap. This flap can then be raised like a regular femto flap, and the residual surface is treated with the excimer laser. Since the anterior and the peripheral corneal collagen fibers are more densely packed, they account for a greater biomechanical strength, which is why SMILE is biomechanically more superior to LASIK. However, 3 cases of ectasia following SMILE have been noted. 2 of them were bilateral cases in patients who had form thrust keratoconus. We have reported the first case of unilateral corneal ectasia following SMILE in a patient with a normal preoperative corneal tomography. Thank you.